will be talking to you all today, really focusing on the genitourinary syndrome of menopause. I know in the program it says female sexual health, but they kind of go together, right? And I only have 15 minutes to tell you about this, where I could talk about female sexual health for probably like 15 days. So I'm also a certified sex counselor, an educator, as well as a certified menopause practitioner, an ISWISH fellow, and then HAES, I'm a health at every size provider as well, which is really helpful for a lot of my folks, and that we don't take weight always into that consideration of like where the problem is coming from and what's going on. These are my pretty robust objectives. I'll let you all kind of just look over those, but the main focus again today is that we're just going to be talking about genitourinary syndrome, menopause, and why is this important for urology providers? Okay, what is the difference? So we have genitourinary syndrome of menopause and we have vulvovaginal atrophy. Well, in 2014, the North American Menopause Society and ISWISH, which is the International Society for the Study of Women's Sexual Health, came together and said, VVA is just not cutting it, right? It's a component of this larger syndrome that we really need to have more conversation around. So what they did is they came up with the terminology of genitourinary syndrome of menopause, and that this really is describing the signs and the symptoms of hormone deficiency that is happening in the female urogenital tract. And that is including the vagina, the vulva, the vestibule, the clitoris, the bladder, the trigone area, the urethra, and those pelvic floor musculoskeletal structures as well. So what are we looking at? What are these patients coming to talk to us about? I have it broken up into kind of 3 different sections here. So one of it is going to be the genital symptoms. They're going to be talking about just feels dry, right? They may have a lot of burning, a lot of irritation in the genital area. They have itching, right, from this loss of hormonal deficiency that's happened. And it's not a yeast infection, right? Like, so we keep kind of coming back to, oh, here's some diflucan and you'll just be fine. They also may be talking about the fact that they're having some abnormal discharge. There might be a different odor that they are experiencing there as well. Urinary symptoms, right? This isn't just a urinary tract infection, even though they're calling you up going, I think I have a UTI. But what they're experiencing, right, is this burning sensation, urgency and frequency that's going on. They may have a stress or stress or urge or a mixed incontinence there, but we also are seeing increased urinary tract infections in these individuals too. And so putting them on prophylactic antibiotics isn't always going to solve the problem. And then on the sexual side of things, right, they may be having pain with sexual activity, pain with penetration. They may say it hurts at the opening. I can't get past this area, and there's a wall. Something is happening, something's stopping for my partner and us engaging in penetrative sexual activities. They may talk about the lack of lubrication that they're having. They just can't get that moisture and that lubrication as much as well. Then we also think about the changes that are happening in that area are leading to decreased arousal, right? That blood flow is changing in that area. We're not having as much surface area. Things aren't as robust as they were. There's this loss of architecture that you're seeing in that area, and that lack of arousal then is leading to this inhibition with this inhibitory orgasm functioning as well. All right, so we want to know, like, all right, this is happening and those are the symptoms, but how many people is this really affecting, right? And it's a big part here. So I want us to think about, right, this is going through menopause. And there is the perimenopause, which can be 5 to 10 years before that final menstrual period. We kind of have this time frame in between, kind of menopause and then postmenopause. So this is a wide range. 27 to 84% of menopausal women are going to be experiencing some form of genitourinary syndrome of menopause. There was an observational study that came out a couple of years ago that looked at, that showed like genitourinary syndrome of menopause was found on 84% of routine examinations, and this was 6 years after those individuals actually went through menopause. The thing I really want you all to take away too from this very brief talk this morning is that this isn't going to get better, right? Other menopausal symptoms like vasomotor symptoms, those are going to eventually go away for the majority of people, but this is not. This is progressive and will continue to get worse as that individual ages. There was this great survey, the VIVA survey, that looked at over 3,500 postmenopausal women in 6 different countries, and they said that they found that 45% of them reported vaginal symptoms that were inclusive of this genitourinary syndrome of menopause, and that 75%, so a big majority of them, actually felt that this negatively impacted their life, their quality of life, and especially their body image and their relationship with their partners as well. Okay, so If these people are coming into your office and they are complaining about these symptoms, how are we actually going to diagnose this? And so when we think about, all right, their symptoms, we got to look. We got to be able to look on this physical exam. I talked a lot about the changes in the architecture that's happening. So there might be labial minora resorption into the majora. You're going to see maybe some loss of adipose tissue in that mons. You're going to see some dryness, right? It doesn't have that nice kind of sheen, glossy sheen on the vulva that you would normally see. You're looking at the introitus, and it's stiff, it's not elastic. You're trying to move around those tissues, and it's just not moving as much. You'll also see that there's some clitoral atrophy that happens. Who in the room, when you do a pelvic exam, who's looking at the clitoris? Anybody? A few people? Yay, okay, gotcha. Right, when I was in PA school, the dreaded thing was don't touch the clitoris. But it's really important because, again, you might see some clitoral phimosis that's happening in that area too. And we know that for about 1/3 of women that are struggling with anorgasmia or reaching orgasm, it is the phimosis. It is the fact that that clitoral hood is not moving or it's stuck onto that glans as well. You're gonna see some friable tissues, right? You're trying to move around in all those little parts and pieces, looking at all the nooks and crannies, and it's bleeding, it's tearing as you're doing that examination. You're going to see paleness, right? This hypopigmentation. You might even see some petechiae, some erythema in that area too, and some ulcerations. On the urinary side of things, right, some caruncles, telescoping. You're going to see this kind of widening of that urethral meatus. You might see some prolapse of those pelvic organs as well, polyps in that area, and then definitely a weak pelvic floor. We have lots of studies out there now that are supporting the fact that we're finding estrogen and testosterone and androgen receptors on the musculature of that pelvic floor. So that is going to be really important for us to focus on as well. Okay, some pictures, right? I couldn't actually just talk about it. I have to show you what's going on. So if you look over here in A, so you'll see that resorption of those labia minora right there. In B, you're going to see the paleness of that clitoral structure, that glans in that area. And when I talk to a lot of my patients, when we're looking at kind of the vestibule and those more internal folds of the clitoris and the labia minora around the vestibule, Hart's line, that's going to be more of a rosy kind of pink color. Doesn't matter the melanin in that person's skin, but that's what we're looking for. And then you can see down here in C, right, do you all see a clitoris? I don't see a clitoris, right? There's this clitoral phimosis that's happening over this area and that thickening of that skin where we can't even retract. Oops, excuse me. How do I go back? Anyways, so we'll see here then too, right? So the loss, the resorption of those labia minora, the stenosis of that area also, so erythema here as well. And then over here we kind of see kind of that protrusion, that prolapse of that urethra, but also the telescoping that's happening here, right? That opening up of that urethral meatus, this narrowing of that vaginal introitus, redness here as well. Okay, so what are the treatments? We have some non-hormonal ones that are out there. So I love a good moisturizer and lubricant that's out there. Hyaluronic acid is good too. Aloe vera can help to decrease some of the inflammation that's going on in that area. There's both topical and oral options for that. And vibration therapy. If we're trying to bring more blood flow back to this area and get that oxygen there to help heal those tissues, there's been some successful studies out there showing that just vibration therapy alone can be helpful. We love our pelvic floor PTs. Who's referring to pelvic floor PTs? Everybody, hey, good deal. We love them. And they're super helpful in helping folks to be able to strengthen those pelvic floor muscles, help with vaginal dilators, maybe do some manual stretching and trigger point release too. But what I have found with my patients from those images that you had seen that look like the images that you saw earlier is that these are the hormonal pieces, or non-hormonal pieces are great, right? It's a Band-Aid though, right? It's not really solving the problem. We're not really helping to rebuild, again, that architecture back into that area. And with pelvic floor physical therapy, that's great too, but if you are fighting against thin tissues, you're not gonna be as successful. So a lot of times what I do when I see these patients is we start with some localized hormone therapy first. I wanna build up those tissues. I wanna be able to help get that moisture back so that when they're going to then, when I refer them to that pelvic floor PT, they're going to be, again, more successful in being able to optimize their pelvis and help with those symptoms that they're talking about. So vaginal estrogen creams are going to be great. So this is going to be, again, your Estrace or your Premarin. are really good to use. Some people don't like the creams, right? They're messy, they have to touch themselves, and they don't really want to do that. So meeting your patients where they're at, you can talk to them about the vaginal inserts that are there too. So Imvexi is here at the top. We have a 4 microgram and a 10. You can use this every day for 2 weeks, and then you back off and just use it twice a week. You have Uvafem and Vagifem for those estradiol tablets in there too. My favorite is going to be Prosterone. This is Intrarosa, and I like this because it has a DHEA component to it. We also have androgen receptors in the vulvovaginal tissues and those urogenital tissues as well. So being able to use that DHEA, I get to flood all of those receptors in that area. So we're capturing the estrogen-based ones and that testosterone or androgen ones as well. And then the ring, right? People love the ring because you can just pop that in, you wear it for 3 months, and then you're good to go. Especially those folks that are using pessaries for any prolapse. This is really great to use, and you can just put it in on top of that pessary, and it'll stay in great for them as well. And then some folks like the oral options too. We have some ospemifene or Osphena there as well. We have to caution, though, that this acts like a SERM, and so for folks who have breast cancer, it's contraindicated for those individuals, and then most of my patients will say there's hot flashes, right? If they're already going through menopause and they're having hot flashes, buddy, you don't want to give a menopausal woman more hot flashes. But this works in a good part of populations as well. And then some of the things to think about off-label, we have androgen receptors in that area, so using a compounded testosterone. This is a 0.1% a cream that you can use. They can mix it with their estrogen cream as well, so you can flood that area. When I am talking to some of my breast cancer patients and they're still a little cautious about using localized estrogen, we talk about testosterone and why testosterone can be really helpful for them in that area too, especially, right, if we've got some clitoral atrophy, right? The clitoris has a lot more of those androgen receptors on it, so we want to be able to beef up those tissues for them. There's going to be some energy-based therapies. The verdict is still out with that. We still don't have enough information and research to show that those are successful in treating those folks as well. So we can't have this conversation without talking about, again, the safety and the side effects that go along with it. I have this conversation with my patients all the time, and part of this reason is what is on that estrase or that Premarin or any kind of estrogen product. There's this black box label, right? Because it has estrogen in it, right? The FDA, despite multiple efforts between the North American Menopause Society and ISWISH, will not take that label off. We know and we have the research that supports the fact that, again, systemic absorption. There was a study from JAMA and several other studies to support this too, when they were looking at systemic levels of estrogen that they did not raise above postmenopausal levels. Again, what about our breast cancer patients? We have lots of data out right now that shows that if you don't have breast cancer and you use localized estrogen therapy, it is not going to increase your risk or give you, or even if you have a family history of breast cancer. If you have breast cancer, there was a study that just came out last year that talked about they did not see any increased recurrence or worsening of that person's breast cancer. However, this was just one study. We need more studies and more research here. What about gynecological cancers? The majority of those are going to be HPV related. So being able to use something that's estrogen based is going to be super successful in helping to improve that patient's genitourinary tract. Cardiovascular disease. This has been long talked about too, again, because it has estrogen in it, but we have to think about the mechanism of action and where that estrogen is going, and that there, again, is very little of that being absorbed into the system. So NAMS came out in 2020 and said, absolutely not. We have the research right now that says that it does not increase their cardiovascular risk. Contraindications, right? We should not be doing anything to anybody that has abnormal uterine bleeding until we figure out why. So this isn't just, oh, it probably is just some vaginal bleeding, not necessary uterine bleeding, and here's just some estrogen cream and go about your business. We got to work those patients up too. And then I work with a lot of the oncologists in the area too to talk about any estrogen-dependent neoplasias that are there too. We just want to be very cautious and have a very individualized conversation with each one of those patients to say, is this going to be right for you, or what are our other options? So takeaways today, I hope that you all know that genitourinary syndrome menopause is really, really common, and that if half of our population is going through menopause, that this is going to be affecting a big part of your population, and that we have to take a look at that as well. Not just because of that there's genitourinary syndrome menopause, but maybe there are other vulvar dermatoses, maybe there is an infection, maybe there's a cancer. I have seen so many people, unfortunately, that have been just kind of passed off and going, oh, this is just genital genital warts, or this is something else, and I've biopsied it, and it's come back as vulvar cancer. So like we have to take a look. We have to be supporting our patients. And that there actually are a lot of treatment availability out there that is also very financially affordable for patients too, especially with the addition of our Mark Cuban Cost Plus drugs pharmacy as well. I always tell people too, we want to think preventatively, not reactionary. So if the majority of our patients are going to be going through this, why are we waiting until they already have a problem? Why are we already waiting? Why can't we have this conversation with them in their like mid-40s, mid-40s, late 40s, early 50s to say, these things are actually going to be happening. If you start to notice some of this, let's have a conversation about it. Let's have you come in. Because now it's not going to take 6 months to a year to really beef up those tissues and build back that architecture. Maybe it just takes us 2 or 3 months, and that patient is much more comfortable and having a lot more success in how they're feeling. And we're preventing urinary tract infections, right? There was a study that also came out that using localized estrogen therapy can actually help to prevent urinary tract infections by over 50%. So we have to be having these conversations with our folks. So thank you so much.